my name is Jamie Schrant. I am an outreach manager for Rogers, and I work with all of our PHP, IOP clinics in the state of Wisconsin, Illinois, and Minnesota and Denver. I do have Travis Nugent here with me today. He is filling in for Dr. Jacoby, who is unable to attend. But without further ado, I will let Travis get started.
Excellent. Well, welcome everybody. Thanks for having me. I know some people were probably expecting Dr. Jacoby, but I swear, hopefully, I'll have his confidence to fill in. So myself, I'm actually trained in marriage and family therapy, and I am currently at the Sheboygan Rogers. Actually, I'm the child and adolescent OCD and anxiety therapist here. So I work with the kiddos. Hopefully, my presentations are usually a little bit more organic and a little bit more interactive. The difficulty is we have quite a lot of people on today. So I guess my objective will be to go through a lot of the information. I will make sure there's probably about 10 minutes, 15 to 10 minutes at the end. The difficulty with that is there is a lot of information on these slides. My recommendation is maybe if there's anything that pops up, just like write it down, jot like maybe there was this thing on this slide we could talk about. I'm going to go ahead and start the presentation. Okay. Well, the neat thing is, I've already seen quite a few names on here. I'm like, oh, I think I know like a few of you, which is really cool. We've got a lot of like teaching personnel, it sounds like counseling inside the school and outside the school. So it's pretty neat. So at the end of this, you will see my information and Dr. Jacoby's information as well. So you can reach out to either of us for more information too. But Dr. Jacoby's not here. You can see my information up there as well. As I stand up for him, we're basically standing for him. We're basically going to be talking about what's relevant, especially with kiddos, in particular with anxiety and not only the school environment, but outside of it. Hopefully something out of here is a little bit more informational, but also something we can all apply. The areas hopefully is just stress in general as a concept. I mean, I'm sure we're all familiar what stress is, anxiety and what are the common anxiety disorders, kind of the evidence-based treatment or psychological treatment that we in particular do at Rogers. And then not only anxiety in the school setting, but what can we do as like a bunch of caregivers can not only support like families, school environments, but kiddos in general. So first off, stress. We're all familiar with stress. I do find it fascinating that oftentimes when we talk about stress, we all have a different concept or idea of stress. And that's why we want to start off by just defining it, at least in the contextual way or the way of how people perceive it. So what is it? It's two things. There is a stressor and there's a stress response. So any stressor could be a situation that a person experiences some sort of feeling of threatening, some sort of danger, some sort of elevation. Oftentimes it's academics. It can be social stress, family discord. We've got a lot of world events, trauma, significant life changes. If anybody in here is a teacher, you know exactly what I'm talking about because there's a lot that is put on us caregivers. And it's like, okay, cool. Can you make sure they're fed and their academics are good, but also play 18 different roles too? So I sympathize and empathize with all of you. Overall, there's a lot that causes stress, and it's not the concept of stress. It's really how we react to it or how we perceive the threat. The stress response is literally just a complex set of physiological changes that help us deal with the stressor. A lot of this is learned through family, through environment, society. But overall, what I want you to take from this is the little blurb on the right there. So basically how we interpret the stressor determines whether it's positive or negative. There's a lot of events that have happened. And as a therapist, if I see somebody for the first time and they say, well, recently my mom passed away. Behaviorally or emotionally, societally, we usually say something like, oh, I'm so sorry, right? Well, as a therapist, we say, okay, and what effect does that have on you? Because that could have been a beneficial thing in their life, believe it or not. Oh man, it's really sad that they passed away, but it was so hard. The idea around it is being curious about what the stressor is and why it's so difficult for them. That's the key to stress. Stress with kiddos. When we talk physiological, we're literally just talking about the response in their body, how it basically responds in their mind. And we all know that that's all connected to their behaviors. We'll go a little bit more in depth into CBT. If I'm sure a lot of you are familiar with it, cognitive behavioral therapy, but really it's just how your brain and body kind of function together, thoughts, feelings, and behaviors. So common somatic responses: headaches, muscle tension and pain, chest pain, fatigue, change in sex drive, stomach upset, sleep problems. I wish we had like less people so I could see everybody and I'd start like interacting a bit. What I would say is, I wonder what the most number one anxiety response that all of you would think would be. Because I can tell you from our end, almost always it's like, oh, I just like my stomach hurts, and I'm kind of like sick a little bit. So we get a lot of kiddos that are like perpetually almost ill. It's because their body is literally just responding to the stress. How's it with mood? Anxiety, restlessness, lack of motivation or focus, feeling overwhelmed, definitely irritable and anger, sadness or depression. One of the things we love to say is where there's anger, there's pain, right? So when we get kiddos with behavioral stuff, usually we're like, okay, what's going on behind it? Behaviors can be tricky because almost all of us are prone to reacting to the specific behaviors without actually understanding the underlying. That's overeating, undereating, angry outbursts, drug or alcohol misuse, tobacco use. Oftentimes, especially when we get to social anxiety or just anxiety as a whole, you're going to see a lot of avoidance and withdrawal. And even taking care of ourselves, exercising less often, less socializing, all this stuff is related. So when we talk about stress, in particular with teens, number one, here's some stats. Most common source of stress, weird, school. I'm sure all of you know that. Well, if I was to point it out, it's pretty much school, so expectations, and then expectations past. So what? College and family. I mean, usually kids want to be loved, accepted, to be built up by their families, to not let them down. So there's just a lot of stress underlying. We'd say 40% kiddos, 40% of teens will report they're irritable, nervous, anxious, fatigued, overwhelmed. I mean, if you look at it this way, 1/3 of our kiddos, all of the kids out there, are probably struggling with some not only stress but anxiety. It's that prevalent. That being said, 51% notice that there's stress that they're able to notice, which we would call like an insight or awareness, right? And about a quarter of that said that were short or even snapped at someone close. And this is all due to stress. Actually, as an anxiety therapist, I literally get kids that say, no, I don't have anxiety. And I'm like, oh, okay, well, tell me about it. And they'll say it and they'll use the word stress instead of anxiety. Has anybody had that before? We're like, oh, I'm just overstressed or overwhelmed, but they don't know that they're clenching, they're a little frigid, So although it can be ambiguous a little bit sometimes, stress and anxiety, we do want to see that all of it's connected. So other sources, maintaining their social network of friends, trying to juggle jobs, relationships, school all at the same time, the multitude of world events. All of us have gone through COVID. We know how difficult that has been, and arguably still is for a lot of people and a lot of kids. Family issues. It's a big part of what I do is I interact not only with the kids, but the family home life. We are going to talk a little bit about that, what that looks like, and what we can do to kind of help kids. And of course, other life changes, moving, new schools, literally could be personal tragedies in their lives. And this goes for all humans, right? Not just not just teens. All of us can struggle in different ways, and half the time we don't know what people are going through. So moving on. Okay, we know that people stress. We know anxiety is fairly normal. But what can we do? And when we talk about caregivers, it's the full spectrum. We're literally talking about parents. Yes, it can be therapists. Yes, it can be teachers. Anybody that is there in front of them. Well, for one, none of us really do well if we don't feel safe. So an environment is key. So making sure that in a classroom setting or in a home setting that we rely on having a safe environment, or at least a place that if kids are struggling, that they get support rather than a sort of punishment. Family routines, family meals. I can't tell you how many times, especially when you're anxious, right? Stomach is like sick and they don't want to eat. So they don't eat. And then they get more stressed. And then they get reactive. And it's like, have you eaten today? No, I can't. I'm like, I know you feel like you can't. But also, like, if we don't eat, you ever seen the Snicker commercials? I mean, we all can be there at least one or twice in our lives, right? I am at least one or twice a week. Okay, the point is, meals, family routines are important. This is a tricky one, right? I think most of us try our best to model good behavior. Managing our own stress is important. You can't be upset at a kid that is doing exactly what you're doing. Or rather, you can, but maybe we need to sometimes ask the parents, well, how are you dealing with stress? How do you handle anxiety? Because sometimes that can give us a window into what the kids have learned. Especially nowadays, kids nowadays, their main connector, their main friends is not in person. A lot of them, so many of them are online. So they're using Discord to connect, messaging. I mean, we all know this, right? It's a lot of video games and social media. The difficulty is these things, but in particular video games, they're made to be addicting. So we've got Fortnite, we've got all these things out there. If we can at least limit or utilize those as ways of, hey, get your homework done, get all stuff done, and then if you want an hour of game time, okay. Is a lot healthier than just kind of letting kids do what they want. Keep children in the loop of changes. Wow, I got an echo from someone. Oh, Jennifer, that's you. There you go. You're going to see that oftentimes parents, teachers, people in power per se, we want to shield kids. And I get it, especially kids are under stress and they're anxious. But letting them know the why of changes, not just what, it can be really helpful for at least helping them understand it. And we're going to get a little bit into this why we don't want to reassure them, why we don't want to explain over and over again, but at least giving them a little bit of loop of what's going to be happening. And when they do have concerns, they do have stress and anxiety comes up, can we listen to them without going, oh, you shouldn't be thinking that way, or I get it, but no, we should be like, wow, okay, I could see where you're coming from. And so yes, and ends up being a lot of what dialectical behavioral therapy comes into, but also just in general, we have to acknowledge that you are very stressed, you are very anxious, and you can't have a behavior that's going to hurt others or disrupt class. And, right? So we can acknowledge feelings and say the behaviors are not okay. A lot of this I will bring up a little bit later, but allowing them to have a little bit of choice and control will probably help all of us because then we're not fighting them. They're working and cooperating with us. And lastly, self-care. How many times do we all hear, oh, self-care is important. I can't tell you, I've met many people, and caregivers are wonderful at caring for and loving other people, but oftentimes we can struggle taking care of ourselves. So making sure you're okay is going to help you help them. At the very bottom, I added this is my personal take. Adolescents, but humans, okay? Adolescents in particular need two things. They need power and they need attention. What do I mean by that? If you don't give them some sort of agency, choice, power, oftentimes kids resort to taking it or doing it and hiding or something like that. And if we don't give them attention, sometimes they just cause problems to get attention. So when we're talking about stress and anxiety in particular, oftentimes kids react to these anxiety, and if they get a response from a caregiver, Oftentimes it can actually make the anxiety worse, not better. So power and attention, if you could like take that as a little nugget for all of you, power just means choice. Attention just means being with them, present. Okay, before we go into anxiety and anxiety disorders, I am going to take a drink and I'm going to slow down a little bit. So if people do have ideas for questions later, you can put them in the chat. That might be a little bit easier too, so that we can all start thinking about different ideas. Since I don't know the familiarity of all of everyone that's here, I'm going to do an overview of anxiety and anxiety disorders, but obviously we can't go too much in depth. Partially that might just bore everyone. Another part of it is you may already know it. It is important, however, to distinguish between the types of anxiety that we can see. And usually we all can see a little bit of, oh, okay, that's what that is. Oh, I wonder if they're trying to be, oh, it's perfectionism. Oh, they're really, oh, it's social anxiety. So when we go to diagnose, to be honest, anxiety is anxiety. The way out of it is through it. However, different approaches for different ones can be helpful. And it's not wanting to go to the next slide on me. All right, there we go. Anxiety in teens. We've seen these things. I imagine all of you have seen these, whether you have a teenager, whether you have a 5-year-old that has these, it's okay too. Irritability, acting out, tantrums. We see things like really clingy, really difficult from separating from parents. Difficulty with sleeping or needing to co-sleep with a parent, even at 9, 10, 11, 12 years old, waking up in the middle of night, having to go to the parents' room, bad dreams, bedwetting. We got somatic symptoms like we talked about earlier, headaches, stomach aches, unwilling to try new things. It can look like refusal. It can look literally like what we call like oppositional defiant disorder or just like anti any kind of authority. But oftentimes it's anxiety and avoidance. You will see that avoidance is probably the #1 indicator of anxiety, because if you think of it this way, when we've experienced a difficult thing or we don't want to experience a difficult thing, the logical thing is just to not try it, not to be around it. So what happens with anxiety is they just start avoiding. It's not just schoolwork, it's not just friends, it could be family, it could be enjoyable activities, and that of course could lead to depression over time. So we'll talk about literally like school-related signs and symptoms in just a bit. What classifies as an anxiety disorder? So these are big ones. These are not all of them, okay? But for one, we need to understand that we need to normalize it. It's normal. Anxiety is absolutely normal. To some degree, we all have a little anxiety. It's absolutely normal for kids of all ages to be nervous and anxious, especially about returning to school, completing schoolwork, taking tests, just doing. Gotta remember, all of us have gone through a lot of things in our lives, right? So yes, we all experience new things, but for the most part, the newness is not there as much. It's more like just a different than we've already experienced, but there's still with kids a lot of new, a lot of new. So I think we can get it. Yeah, if you email me directly, everyone, I can get you a copy of this as well. Normal anxiety is usually transient. Different way of saying it comes and goes. It's normal. You're going to be anxious about a test that's coming up. When you take the test, you might be anxious about if you got a good grade or not, right? But then, it waxes and wanes. Also, anxiety that's problematic is usually associated with increased levels of distress. It tends to be chronic and leads to interference in a lot of areas. It's not just school. It can be home, social relationships, personal relationship with self. And usually, as we've picked on earlier, children learn to avoid. They avoid the people that were distressing, the places that are hard, the things that trigger anxiety. Avoidance ends up being a sort of end all, if you will. The two other things that we kind of focus on, at least here, the big three, is avoidance, isolation, and rumination. Constantly thinking about what happened, how I should have, how I shouldn't have. And when we talk about these things, it's just really, really difficult to convince a kiddo that feels like they've been surviving or their anxiety's been helping them by isolating, by pulling back, by avoiding difficulty, no, 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 no. You're going to be less anxious when you do it, when you're through it. But oftentimes, this is where we're having significant academic and social issues. Maybe they're even struggling to control anger, experiencing big outbursts. We get it pretty common, and it's more like you start seeing the pattern. When kiddos come into Rogers, the few things we're doing is, number one, figuring out what is the anxiety, what are the triggers, and what in particular is the root. You have to get to a root. Social isolation, social anxiety may not just be afraid of people. It might be afraid of letting people down. It might be afraid of failure. It might be afraid of rejection or abandonment. So when we do these particular plans, number one, we have to figure out what the core anxiety is. And then we have to figure out, what is the specific diagnosis? If it's generalized anxiety disorder, if anybody has that in here, it's normal. We just classify it as worry. Worry, 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 worry. Oh, well, what's if? What's if this? What's if that? What's if this? Approximately, what was like 5 minutes ago, I said, all right, I'm going to pause. I'm going to drink and I'm going to slow down. I'm a very excitable person, and I'm like constantly wavering between worrying I'm going too fast and worrying that am I not going to have enough time for a talk? Does anybody do this, by the way? Because I see at least some of your videos. Yeah, that's normal. We got to have a little bit of, okay, what's that? What's this? So we can react to it. When it's GAD, it is so engrossing that it becomes almost debilitating. Now, these four under it aren't under generalized anxiety disorder necessarily, but they are ones that we definitely look at. Separation anxiety, that happens the further you get away from the safety, the more ramped up the anxiety is. Social anxiety sounds pretty self-explanatory, but that's usually the core is rejection. Selective mutism, we have panic disorder, which is definitely different classified than just panic attacks. I'll go into a little bit of detail in all these, so you don't need to worry too much. And then OCD, or obsessive compulsive disorder, which I'll explain the difference of those things. And I'm sure a lot of us have heard of PTSD. It does get thrown out there a lot of times when people have anxiety and they've experienced traumatic events. It's just really a kind of a tricky balance between having them engage with it, having them sit with it and move on all at the same time. But let's distinguish like a little bit more detail between these in case people don't know. I said GAD is essentially worry. It's got to be excessive and to a point where it's just difficult to control. And it has to be over an extended amount of time. We're talking at least 6 months. That includes the welfare, safety of family and friends, finances, relationships, punctuality, school performance, world events. You will get symptoms like irritability in particular, muscle tension, fatigue, unable to sit still, maybe a little fidgety, and poor concentration. Difficulty with this one is it doesn't matter how many times we answer the question. Oh, well, okay, well, what's if I fail on the test? Oh, I'm sure you won't. You're a good student. I know, but what's if I get it wrong? Then it's like, okay, well, then it's just one wrong and you'll have like a A- then. No, but what's if like one wrong? And then it's like, oh man, this is never ending. Has anybody experienced that, by the way? So the idea is our natural response is to answer their question oh, they're obviously worried and I can help them out. All of us have the answers. The difficulty is you actually are feeding into their worry because you can give, and they're just going to be worried about the next thing. So it's not easily reassured. You may have 10 reassurance if they go, okay, thank you. Okay. But what if I've seen it quite a bit, especially in the beginning when we don't give in to their questioning. We're like, I don't know, could be. Yeah, you might fail, you might not. We do a lot of ambiguity, a lot of yes and or maybe. And the truth is because I don't know half the time. And none of us really do know. right? Like if a kid says, what if I get in a car accident on the way home? Now I can go through a whole, well, you're wearing a seatbelt, cars are good. I mean, I can go through a whole thing. It's really low chance, yeah. But it may not be enough. When they don't get what they want or it's not enough, they can get real irritable, especially in younger kids, but I have seen it in even middle schoolers. Tantrums. It's just bursts, little bursts. Poor concentration and attention, especially in school. Real fidgety. You'll see that they may be the one that raises their hands all the time, the one that need to know what's happening next, the who, what, where, when, why. And it really can be sometimes misdiagnosed with ADHD. It can be literally the kid, they can't concentrate. Well, the reason I can't concentrate is they're anxious that they miss something, that they're not listening, or all of that, right? Separation anxiety usually happens in young kids, most common 5 to 7. It does happen, that 11 to 12-year-olds, we've seen that as well. But it's generally separating from home or parent. I'm a father, and my oldest rather, when he was real young, it was a daycare. We hadn't ever had daycare for a while. He was 2, and it became this thing, okay? Bring him there, and he was like, he'd just look at me, and he was a really good communicator at 2. But he would be like crying and be like, Dad. And what's the natural response? Well, I'd pick him up and be like, it's okay, buddy. I know it's hard. And I'd like rub his back and I was like, but you gotta go, right? So I'd like set him down, I'd get him in there. And as soon as I would get like 4 feet away, he'd be like, and it just became this thing where I thought I was helping. I just kept going to him, being like, it's okay, I'm gonna comfort you. Because in particular, as parents or most of us caregivers, it feels like we're actually doing something. The difficulty is every time I was doing that, it became this dialogue where that's the only time he felt safe. So it felt kind of mean or sad that I would have to disengage. And then I know he was stressed. I know he was anxious, but kids get through it. All of us have gotten through things. But it usually typically occurs with significant change, major life events. I know they put in here like divorce, illness, moving. You got to understand that at a kid level, anything can be a major change, right? It could literally be a parent getting a new job. It could be changing work. It could be anything, really. So we have to take in consideration that changes do impact it and kind of pop it. However, it's usually we just have to encourage them to adjust rather than us caregivers adjusting to them. Behaviors, clinging, shadowing behavior, nightmares, expressing fears like loved one. Well, what if you go away? I might not ever see you again. Maybe dying or gone. We've got, as far as like school wise, you do get a lot of like school refusal. I won't even get out of my car to get in. Somatic complaints are a big one. Parents will get a kid in the car. They'll drive them to school. They'll be going late to work, mind you. And they're like, okay, you got to get into school. Because like, oh, I can't. I'm just really sick, So it's all connected. We get anxious. We feel sick. And then all of a sudden, the caregiver's like, oh, no, we have to help them. And it kind of perpetuates a cycle. So social anxiety, we do see it quite often. And for most of us, I would think all of us at one time have had a little social anxiety. It's when you talk about social anxiety disorder, it's excessive. That's all you need to know. Excessive fear in social situations where they could be exposed to unfamiliar people, evaluated by others. So like even raising hand in class presentations, friendships, things like that. And oftentimes tremendous concern about failure, embarrassment, humiliation. A lot of times what we end up doing is we have them face it, at least in a controlled environment. We say, oh, man, that must be hard. We go into the rumination and we say, man, yeah, they might be thinking bad things about you. Now, that may sound really backwards to people, but I'm going to explain a little bit about anxiety after we go through these disorders. We talked about avoidance or endurance with extreme distress, and interference in functioning, of course, not being able to go to school, few, if any, friendships, isolation, all the hallmarks. Select mutism. This can be very tricky to handle as a teacher, as a parent, as a therapist. But it's usually when children either talk very minimally or not at all, especially in certain situations or people, like certain teachers, classmates, meeting new people. I know a kiddo that, it would sound like a mouse. You talk to him, you'd be like, I don't, and you'd be like, what are you saying? I don't know. And you're like, speak up. And then when they do speak up, it's like, I don't know if I can. It's like this echo, like a little like, woo. Um, it generally just reflects underlying problems with anxiety. It's not oftentimes an educational or like a delay or anything. It's really anxiety is the mutism. What's the difficulty thing is what we see in particular. You know what happens? Parents just speak for them. Like, oh, well, actually, I think what he is he's really tired right now. That's why he can't concentrate. And it's like I'll literally ask. I'll say I'll say, so kiddo, like what makes you feel like really anxious? And it'll be about 3 second pause, and then the parent will jump in. Well, they're really anxious around this, 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 and this. So if you are teachers, if you have like parent teacher conferences, and you do have a quieter kid, I would encourage like, oh, I really appreciate your response. I'd really like to hear from your son or your daughter, or however they identify. But or permitting the use of nonverbal, doing these things just perpetuates the cycle of staying quiet. And it's really just considered the more severe form of social phobia. Panic. Usually this is the time where I say, has anybody had a panic attack? And we only have a few people on camera if anybody wants to admit it. Me, I've had one while driving and it came out of nowhere. Worst experience. And as a therapist, I'm like, it's okay. It does not last. I'm like coaching myself. I do not have panic disorder. It was just random anxiety attack, overwhelm. We know that it's sudden. It's usually discrete episodes of intense fear, intense desire to escape, doom. We really just get this like lizard brain part of us that's like, oh no, oh no. It's usually an activation of the I can never say that word, autonomic nervous system. That's that lizard brain part. And mine, I literally did this as a countdown. I tell kiddos, I tell family members, listen, your brain can't be activated that high. So it's usually about 15 to 30 minutes. And if you've had a panic attack, you can literally go, okay, it's been 20 minutes, like telling yourself it's gonna end. You just need to know that it's pretty common. 20 to 30% of adult populations have had a panic attack. So you got to think of that. That's what, 20%. I mean, that's 2 out of 10, 1 out of 5. We have how many people here today? So I know some of you had one, and I appreciate a couple of you raising your hands. The distinguishing piece of the panic disorder, though, is it's recurrent. It keeps happening over and over again. There's inter episodes, essentially really, really, real high worry. I'm worried if I do that, I can have a panic attack, which, by the way, causes panic attacks. We worry about the implications, the consequences. No, if I have a panic attack, everybody's going to look at me. I don't want to go to school. I can't go to school, right? And so you get like these abrupt almost changes in behavior. And it is more common in adolescence. It's really hard to see that graphic, but what I would really sum it up with is we get a somatic or body feeling of discomfort, like hard time breathing, heat, feeling like a little shaky, and we go, oh no, I think I don't like it. And when we say, oh no, and we worry about it, it literally perpetuates us right into a panic. So a lot of what we're doing here is like, yeah, I know you're panicking. And we actually help them a lot with getting panic symptoms without also overreacting to them. PTSD. I'm going to kind of try to move through so we have enough time for questions. PTSD, I'm sure everybody's heard this to some degree. Just understand that PTSD does require an exposure to an actual or a threatened, like death, serious injury, or sexual violence. The idea here is it's a real event that has happened. That's what creates the traumatic event. And PTSD hallmarks is you re-experience it. You re-experience the trauma. It's like an echo over and over again. Avoidance. Naturally, a hallmark of almost all of these anxieties is going to be avoidance. Thoughts, feelings, people, places, anything that has to do with the trauma. So it's very difficult if people have been in a car accident and it becomes traumatic, It's very difficult to have them go back into the car or a car. But our brains are very unique. It could be red cars. No, I remember I was in a red car, or now I have to be in a truck because they're a lot more safe. We make kind of rules for our brain. And then a few other things with PTSD, negative changes in thoughts and moods. Oftentimes, it's the emotions are associated with the guilt, fear, and sadness. So we tend to have this social withdrawn, maybe decreased expression, a hard time experiencing positive emotions. So it gets kind of this almost echo of depression along with this anxiety. And the arousal's there. You're irritable, can be hypervigilant, exaggerated, startle. Imagine this: our body is literally aroused, which means we're worried there's a threat, a danger to us. So your body and brain are doing this vibration, and it's a lot of energy and mind energy. So people with PTSD, whether they're working through it or not, oftentimes are just exhausted and they're irritable and they don't even know why. Well, they're going through quite a lot on the inside that we don't even see. Going on to OCD, which I have extensive experience with. It's a fairly low prevalence if you think of it, 1% to 2% in childhood rates. But at least half of adults report that their symptoms of OCD began in childhood. We do get adults that just kind of get activated, and it's usually some sort of event, but oftentimes it is a childhood kind of repetitive repetition or cycle is what I was thinking. Bimodal distribution of age of onset with first peak, usually around 11. Second peak is early adulthood. You're looking at 17, 18, 20, 21. And male preponderance in childhood OCD diagnosis. Boys are usually diagnosed at a younger age, and the mean age for onset for children is usually about 9 to 11 years old in boys and 11 to 13 in girls. We've heard OCD. Anybody have a friend that's like, oh yeah, I mean, I like that. I'm pretty OCD about my laundry, right? Or fill in the blank. We have to understand that OCD is a specific diagnosis because it's recurrent, intrusive, unwanted images and impulses. So oftentimes people get like, oh, I'm just really OCD about my laundry, dishes, whatever it would be. But they almost associate it as a positive identity. And this is unwanted. They are not excessive worries about real life problems. Honestly, patients often describe obsessions as silly, senseless, bizarre. I've had a patient that's like, I have to step in threes because if I step in threes, then I know there's a higher chance that my loved one won't die. And I'm like, oh, okay. What happens if you step in fours? And they look at me like, are you crazy? And I'm like, well, what makes you think that threes is the magic number? Do you know that like 3 in some cultures is a really scary number? And then they look at me like, wait, what? Okay, what's a better number? And then I'm like, so they're searching almost for this magical thinking, right? They know that it really oftentimes doesn't improve things, but it doesn't feel right unless they actually do the thing that they feel. But because obsessions are unwanted and distressing, people literally try to resist them, get rid of them, reduce their distress in every single way. They avoid triggers, they distract themselves, and oftentimes have a lot of compulsive behaviors and thoughts. So OCD is very tricky to treat. But to give you kind of an idea what we mean by obsessions and compulsions, because most people hear OCD, they think germs. Yeah, it's prevalent, and I've had a lot of kiddos with contamination, but for the most part, it's varied. It's all over the board. Oftentimes they have a responsibility piece, which is fear of harm to either themselves or loved ones. I had a kiddo that was on like a 4th story of a house with a barred window, mind you, and they're afraid that someone's going to climb up, saw through the bars, go in there, and then like hurt them and their family. So they refuse to sleep in their room. It's like this idea of, I don't know who would do that. I'm like, wow, are they Spider-Man? Like, how would they get up there? I use a lot of humor on purpose to kind of like dysregulate a little bit because it can be fear of contamination, fear of harm or danger, fear of just loss. I have to collect things because I need to know where my books are, papers, receipts, trash. This is different than hoarding, but it can have hoarding-like behavior. Need for symmetry. need to have the room organized in a certain way, or things in a certain thing. I had a person, if they ever opened a door with the right hand, they would have to close it with their left hand because it just didn't feel right. See, need for perfection. There's a difference between perfectionism in a anxiety sense and in a obsession way or OCD way. But the idea is need for certainty. Like I need it to be right. I need to know. And if I don't know, like you might get some explosive behaviors. And interestingly enough, fear of anxiety. Oh, I'm afraid I'm going to be anxious. So diagnosis, when we talk about compulsions, we also call them safety behaviors here. Honestly, compulsions, it's the feeling you almost need to do it to feel safe. Um, it's any behavior or mental act that a person feels driven to perform. And it's usually repetitive over and over again. To prevent and when you do it, it feels like your anxiety goes down. And so does your discomfort, so does your distress. And a lot of times what we hear is just to prevent a bad thing from happening. If you ask a kiddo, well, what bad thing could happen? Ah, I don't know. I don't know. I just want to stop it. They don't actually go down the track of what a bad thing would happen. They may say, I'm worried. I don't want my parents to get in a car crash. And I'm like, I understand. What would happen if they did? Oh my God, that'd be so terrible. And I'm like, I understand. Well, what would happen afterwards? And you have to get them to a point of seeing, oh, they would go to the doctor and maybe they'd have surgery and then maybe they would get better. Oh, okay. But OCD doesn't necessarily work on a logic sort of things. A lot of it is it just needs to feel right. And they're very rigid rules, and then they kind of make them up. They get to decide. Rather, it's just kind of pointed on them. Examples of some compulsions: washing and cleaning, hand washing, grooming, toilet routine, brushing teeth. I've seen people have to wash their hands for 45 minutes. Their whole hands are raw. And they're like, but it's the only way I know that I'm okay. Hoarding, collecting, saving receipts, useless things. A kiddo had a really, really, really hard time getting rid of a paper clip. A paper clip. I'm like, you can get a new one, and they're like, no, but I don't want to use this one. This one has use, and it became like, oh, from the outside, we're gonna say, wow, okay, they're really good. They're like very good, utilitarian, if you will, minimalist. Oh, wow, these kids are great. Well, they're having a hard time because there's a lot of us anxiety associated with it. But ordering and arranging, repeating any kind of ritual, it can be rereading, rewriting, retracting steps until it just feels right. It's good to know because you're probably going to be seeing a lot of these potential symptoms that not only is OCD, there's a smaller population with OCD, true OCD, but there's a lot of what we call impulse controls or other factors. So pathological gambling, kleptomania, or just feeling like you need to take things, certain substance use of disorders, and a big one that has probably come out this last year and a half, video game addiction. You have to understand that we could say, oh, I don't know, I have to, right? But they generally enjoy it. And if they enjoy it, it's not unwanted. And if it's not unwanted, it's not OCD. So I guess that'd be like in a nutshell. Let's go through the evidence-based treatment. And I have so much information with so little time. I'm gonna take one more drink and we're gonna kind of fly through this part, okay? Anybody not familiar with the CBT triangle? I I know there's a lot of you here and people probably can't answer. Cognitive behavioral therapy just focuses on how thoughts, emotions, and behaviors all are connected. They're all intertwined. So if we think, oh, I'm dumb and I feel alone, right? I'm going to behave in a way I don't want to talk to people. I already feel kind of dumb and I feel alone, which interestingly enough keeps them alone. So what we have to do is focus on what they can control. Thoughts are very difficult. We can fight them, if you will. Emotions, we have to teach them to kind of get through the emotion, but behave. We can all do something different. And a lot of that you'll see is not isolating, not avoiding. In a nutshell, this is anxiety. Fear of dogs would be a good example. The situation is seeing a dog, thinking, oh no, what if that dog is scary? Avoiding it. You feel safe. It reinforces that you feel safe only because you avoided it. So the reinforcer here is you feel safe only because you avoided it. And I could say that 18 times because I need you to hear it. We've literally taught our brains that the way we feel safe is to not do a thing. But if we do that with schoolwork, with social, with family, sometimes we don't know how to function outside of just withdrawing, avoiding, and isolating. We call this habituation, a fancy word for we all get used to our habitat. If I could see, let's pretend there's a random mark where the word anxiety is, that would be like a trigger. If we don't do anything, anxiety does go up a little bit, and then it just naturally goes down over time. Good example is motorcycles and fireworks. Almost all kids are really scared of that because it's loud and scary. In nature, we don't hear those things unless it's like a bear or something. So our brains are like, what's that? But I don't know about all of you, but if I hear motorcycle now, my brain goes, oh, there's a Harley out there. And that's it. It's flat. So we absolutely know if you do nothing with anxiety, your brain starts to realize that you're not in distress or danger, and it will go down. So when we talk about safety behaviors, this is kind of what it looks like. Anxiety goes up. We all find ways to make it go down. And I told you a lot of that is avoidance, but it could be anything. I've seen a patient, it was not OCD, but they just felt like this was the way they could do it. And their whole family was religious. And I was like, excellent, that's really cool that you have that background and value-oriented thing. And they're like, yeah, whenever I get stressed, I just pray. And I was like, okay, cool. So you kind of pray for guidance, protection, strength, whatever it is. Wait, how many times do you pray? And they're like, well, probably about 45, 50 times a day. And I was like, oh, okay. So anytime they would get anxious, they would utilize the prayer to feel safe. Now they've taught themselves over and over again, the only way to feel safe is if I pray. Now that's not inherently bad, except for if their life is being shut down because of it, right? School, social, family. So what do we not know? In essence, all these safety behaviors, well, they work. They work to make us feel safe. The problem is they actually perpetuate anxiety. This could be reassurance requests, compulsion washing, carrying a bottle of water, or any kind of like PRN medication, like, okay, well, I need that just in case. Needing to sleep with parents, avoiding eye contact, standing with another, using substances, avoidance of triggers. A lot of this is just learned behavior and perpetuated. So what does our treatment look like? Well, you can see that we actually purposely find the red line. We purposely have them be anxious, and we intentionally have them sit with it. And we're actually teaching them to endure and get through it. And then they're teaching their brain that, okay, anxiety is scary, but it's not dangerous. So this is really what kind of, at least with our model, we use a CBT model, cognitive behavioral model. It's called exposure response prevention. Each time you do kind of a similar trigger and let them go down naturally, then the time that you trigger again, the trigger is not so high. Is that making sense? You can kind of see by the model, that's the same anxiety trigger just popping. And each time they're doing it, their brain kind of goes, oh, okay, I get it. I get it. Some of these things I'm going to kind of skip through fairly quickly so we have some time. But challenging negative thoughts or just in general, one way of with our thinking is I'm dumb or I always make mistakes. No one loves me. Whatever it is, we have to get them out of the trap of catastrophizing, out of it. They usually go, oh, I made a mistake. Now they're going to think I'm dumb. Now I'm never going to have a good job. Now I'll never get into a good college. Ah, my life is ruined. You have to challenge them. Like, what percent chance is that true? How many times has it happened before? Well, I mean, what's the worst that could happen? And you have to kind of guide them. These are actually tricks you can use in the school, by the way, is I understand that you're really worried. If it was really to happen, like, what do you think you would do? I don't know. I'd be sad. Okay. And then what? Well, I'd probably move on. Okay. All right. You can handle it. I know you can. Speaking of anxiety in the school setting, what can it look like? I'm sure all of you have seen this in some degree, whether it's school setting or outside of it. Withdrawn or overly dependent, flat, overly emotional, complaints of physical symptoms, physical symptoms, difficulty concentrating, reassurance seeking, the changes in grades and behavior. The difficulty with this is if you look at this list, one kid will have like a couple, right? And a different one will have different ones. So we can just like we can understand that anxiety is normal and we can see it in kiddos. And remember, stress is pretty prevalent. So we can go, okay, they might be a little anxious. So connecting with them on that, or at least asking about, hey, I've noticed that you really fidget a lot. Do you know what that's about? Not all kids can have the insight of understanding themselves, but it can get them to start thinking, oh, I don't know. I think it's because this. You'd be surprised. A lot of kids have the answers for themselves. These are oftentimes the behaviors that we can see. Checking for mistakes, rewriting, erasing, rewriting, erasing, rewriting. Incomplete assignments because they need to have it perfect. So they'll have, on a math test, they'll have 10 questions. 7 of them will be fantastic. And then three of the ones won't even be started. Repeating, seeking constant reassurance. I know some of the stuff repeats. What you need to see is they're just so common that you should like start picking up. Oh, I get it. And difficulty transitioning between home and school. At school, I was an over-apologizer, 100%. I'm sorry. I'd walk into a room. Oh, I'm sorry. Did I interrupt? And maybe there's a couple of you in the room. I don't know. It's okay if we want to check in if we're doing stuff. But if we're over-apologizing, oftentimes we're anxious. Isolating, academics, difficulty with tasks. Social impact usually is when we avoid more. We tend to have difficulty with bullying, peer conflicts, not being able to get through things. And then other things like truancy, very common on our end. Chronic lateness, very common. Family conflict, very common. And obviously performance. Here are some interventions. Here's a difficulty. Probably my role, not only helping kids here, but my role is helping the parents oftentimes have consequences and following through on things, having expectations. Another piece of it is interacting with the schools, because not only do parents accommodate, which means kind of give in, be like, oh, it'll be easier. Oh, you know what? I'll get your jacket for you, or I'll tie your shoes for a 12-year-old. Okay, to get ideas, we do things for them thinking it's helpful. And that's fine to begin with. We can help. If they're going to be late, I understand it's already hard to get up and get in the door. If you want to be 15 minutes late, that's okay. But we're going to reduce that from 15 to 10 to 5 to being on time. Some things that happen in schools, well, they're really anxious, so they only go half days. Now, this isn't necessarily the school that does this, but it can be. It's oftentimes the parents. Well, Johnny is so scared, he has such a struggle with school. So like, I'm just going to keep him back a little bit, that actually perpetuates the perceived danger of school. Nope, get him in. I know it's hard, but we're going to help him. Allow extra times for transitions. That may be a temporary intervention that we need to do. Having a safe place if a child develops increased anxiety or panic attacks. What you need to see on there is it must be time limited. Just because a kid has a really, really hard time and maybe they're worried and you're worried that they're going to have a behavioral outburst, that's fine. I'm sorry that you're having a hard time. Yeah, go ahead and take a break, buddy, for 5 to 10 minutes. And then you got to come back. None of this, oh, he's having a hard time, get him out of the classroom fully. Or what oftentimes happens is they go to their counselor and they rely on the counselor then. They're safe in the counselor room, but they're not in the classroom. So we got to set some boundaries where, yes, we can talk to you, but it's time limited with the expectation of you still have to do it. And overall, have a plan. Include coping cards that can help. Anything that because when we're all stressed out, nobody goes, what skill should I use? But we can sometimes be like reminded, hey, why don't you look at one of your coping cards and try that? Well, I don't know where they are. Oh, here it is. Okay. And it will tell us what to do. Man, so many slides. We are almost done with slides. I did want a few questions, and I imagine some of you do have to go time limited wise. I'll stay back a little bit if you do have questions. But returning to school, some things. Visit the school, teachers in advance, maybe have a list of questions that the child can ask. That's the who, what, where, when, what to expect, tell them what the transition looks like. Maybe do a practice run of getting up, getting dressed, driving to school. We actually have kids with that anxiety when school's out. We'll have them go to school, go up to the door, touch the door, imagine being inside. We got to normalize that everybody, all of us, feel some sort of anxiety and stress. Validate that it's really hard and difficult, and they still need to try. Encourage them to share their concerns and worries rather than holding it in, isolating, right? And help them problem solve. It's okay to have anxiety because sometimes that makes us go, oh no, I'm going to be late. Problem solve. I've had to kind of problem solve to get through some of these. I'm like, man, I got to get through these faster, right? You can role play tough situations. Focus on desirable aspects of school. Oh, but remember, you love gym class, so I know English is hard, but right after that, you get to do the fun stuff. It's almost like a mini reward. Model your calmness and confidence. And last is, I know I've said it a lot about avoidance. Avoidance is probably our number one reason why the kiddos feel okay, but don't perform or don't actually get better. So try to really encourage them not to avoid. Where to find treatment? This is just kind of wrapping up. There's a lot of treatment options, and even when I was doing it as an outpatient therapist before I was at Rogers, I did a lot of family, couples, and kiddo counseling, and that was outpatient. So that can be from mild to moderate mood anxiety, and it's usually where we would step out, right? And maybe it's the first step. But if they're not getting help enough with that, if it's a little intense, we have a few different options. IOP, intensive outpatient programs, it's kind of a hybrid. Usually kids come for 3 hours a day, and then they'll go to school for the other half. And then we work with your school counselors to make that work. Residential is probably the most elevated up, and that is where they actually sleep there and stay there. That's generally when we have really, really difficult functioning. Inpatient is more for stabilization if they're suicidal or can't function, maybe like psychosis. And then sometimes virtual. We utilize virtual a lot, but it is not ideal. But when people are an hour and a half away, I mean, it's a great option. So in summary, anxiety disorders are the most common emotional and behavioral problem in child and adolescent, which means it's probably one of the most emotional behavior problems at school. The avoidance of triggers and anxiety is probably the number one reason why it maintains that anxiety. So we've got to stop them from avoiding. And the high success rate treating anxiety disorders, we utilize behavioral therapy with an emphasis on exposure. I do notice that somebody put something exposure therapy in the chat. In a nutshell, if you don't know exposure therapy, you can kind of like Rogers, we can help out. Otherwise, just the idea of exposure therapy is being exposed to what's difficult and then getting through it without doing the thing to make you feel safe. I can get you, I think Jamie said you all get access to the slides, a lot more information here. And 1 minute for questions. Yeah, that was a lot to get through. Like I tried my best there, but all right. Do we want to speak up or are we gonna do chat? We're gonna chat for questions, okay.
Yeah, or if you do want to ask a question directly, just raise your hand, use the raise hand function. Travis, I do see one in here. How do we, the school, work with students that have anxiety and the avoidance is not coming to school at all? Parents can't get them up or get them in the vehicle to come to school. Thinking, and this is coming from Ben, and he's thinking it's more like high school age.
Yeah, Ben, this is a tough one. I'm not gonna lie. When I say tough, it's for lack of a better word, the intervention is with the parent. So it's a big part of my job, to be honest, is when kiddos are in here, I get to know the parents, the family dynamics, and I say, so tell me about it. And they'll say, well, he was just really struggling. I'm sorry we're late, and then I'm like, well, what happened? Well, he needed to brush his teeth. And whatever it is, I won't call it excuse, but what happens is the parent ends up becoming a defender or protector of the anxiety, almost like, well, I need to accommodate so that their anxiety goes low. And it's not the parent's fault. I would say 90 to 98% of all of us accommodate to some degree. Our loved ones, our kids, our partners. It's because we want to feel like we can help them. How do you intervene with this? Oftentimes, I would intervene with the parent. I would say, we're noticing this, and by the time we, as in you or us, talk to them, they usually feel so debilitated and powerless that they're like, okay, I don't know what to do, So we have to understand what are they doing to help the anxiety, and then you have to talk to them about how them helping the anxiety is actually making it worse. If you want a practical intervention, it's usually a parent is unwilling to follow through with any kind of consequence and instead actually almost rewards their behavior. So the discussion goes, okay, I understand that they're not coming and it's really difficult for them, but we also know avoidance is actually making it worse. So in order to be able to keep going, can can you say, I expect you to go, so higher expectations, and if you don't go, then you're not going to have computer time. You don't computer time, you don't get this, you don't get your phone, and unless you go to school. That usually is enough for kids to go fine, but we also know teenagers are like, forget that, I don't care, do whatever. It's a struggle, and oftentimes I would encourage, in particular, if this is a repetitive pattern, please send them our way. Our programs are really good at intervening with that while also getting them back in school, or even an outpatient ERP therapist. So I don't know if that helped. I know it's just a big topic. So okay. Thanks, Chris, if you're still here.
I see that we do have another question here from Melissa.
There it is.
If I have a student who has anxiety about coming to school and anxiety persists the more they miss, avoidance is the issue, but we can't get them here. How do we get them to school?
So my understanding, Melissa, is so they get anxious, like let's say about school, they miss more school, and then they're like, well, I can't catch up, or now it's even worse. Like, am I understanding that right? If you're still here, you can verbally talk. Not, I'm just going to answer it based off an idea. Okay, well, I'll just answer it based off an idea for anybody listening to that one. Again, tricky, right? I think there's a lot of emphasis too on the school and teachers and staff. It's like, why isn't your student coming in? We got to understand this is a bigger issue. And this is a perpetual sort of, the more we, I'm gonna try to reframe it. This is a true example, all of you, so I'm being a little vulnerable. Dishes. I don't have a dishwasher. I'm a single dad. I've got a lot going on. I work here. I've got a second job. I've got sports for kids, all these things, right? So I'm like, oh, the dishes. I'm like, that's fine. I'll just do them tomorrow. So then I wake up and I go to like have coffee and I look at the dishes. I'm like, oh man, okay, I gotta get to work. I'll do it later. And the longer they're there, the bigger the mountain seems to be. So a lot of this, what I do is, you know what? Can you do one at a time? I know I know it's really, really difficult to get into school. How about, can we come in for 1 hour? It's usually for a lot of us, this is usually a depression technique. It's a 5-minute rule. Can you do it for 5 minutes? And if you do it for 5 minutes, sometimes we're like, well, I'm already here, so I guess I'll just do it. But it's usually just that initial getting in. Otherwise, the intervention oftentimes is with the parents, which is a lot of, is there a way that we can initially reward them for coming in, and or again, make their home life not fun, because we don't want a kid avoiding school and playing games, right? So I know that probably didn't help specifically, because I know that that's a perpetual issue.
I think we can answer Christian's question, and then we probably have to wrap up for the day. But yeah. Kristen says here, in your IOP or PHPs, if they have anxiety and do not attend due to anxiety and avoidance, do you have an attendance policy? And I believe we do, right, Travis?
Yeah, we do. So we have what's called a goals list, right? And it's what it really is, it's behavioral agreement. And the idea is, hit certain factors and you can stay in the program. So you tell that to kiddos, and some of them are very like, oh, so if I don't hit those, then you'll kick me out. Awesome, right? So there's a lot of maneuvering that we do have to do, and there's a lot of flexibility within this. So the IOP programs and PHP, if they don't attend, a lot of it is, again, intervening, me in particular, a therapist, intervening with the parent. And it's the same things I'm talking about: expectations, consequences, rewards, motivational interviewing, trying to get a hold of the kiddo over the phone, and being like, so what's getting in the way? What do you think's going to happen if we don't tackle this? Those type of things. In essence, we have a 3 and out. If you have 3 absences, that we should be looking at ethically. You can't be in a program if you're not, and the other kiddos could benefit from it. That being said, we do a lot of leeway on this, because if we just say, oh, you're not attending, you're not going to be in the program, how are we going to help them? We're recognizing that this is a perpetual pattern with school, and now it's the same thing here. So we do a lot to intervene, and that's individual and family interventions. What happens if parents do not follow through? Yeah, oftentimes we'll recommend maybe a higher level of care. If the kiddos can't get in, then we say, okay, it's evident that either it's the parents, the family, or the kiddos having such a hard time that maybe they need to go to residential, where they will live there and do the programming, because then they don't have a choice. And I know it sounds maybe cruel, but man, I've seen that work wonders for kids, because they're out of the family environment that says, oh, it's okay, you don't have to. Yeah. So, well, I really appreciate all of your time. I know I'm not Dr. Jacoby, but hopefully I filled in okay. I do have both of our information on there. Yeah, feel free to email me if you do have questions I did not answer, if they pop up afterwards. It was really cool to have a presentation with everyone. And thank you.
Thank you, Travis, and thank you, everyone. We will send out the PowerPoint slides to you yet today. Have a great afternoon.
Excellent. Thanks.
Bye-bye.